curious about something, to just, I guess, tell Hannah or tell me or to add it to the schedule. This is kind of first one. We'll kind of start with eyes and O's and daily ways. We try to make it more relevant to things that you guys are involved in, bedside stuff. I'm not going to kind of talk about latest research in MS. I don't think that's really relevant. And it helps me to kind of get, oh yeah, it helps me to kind of keep up to date. And also, I think it helps us all work together because I think there's a lot of valid points here, both that, us as providers we have to do and you guys at bedside. And the reason we want to do eyes and nose is it's very important to do. We'll talk about all the conditions that involve, like why we really put the order in. Um, and the main thing is a lot of times we put orders in that are maybe necessary on admission, like maybe overnight if people put in this order, but the patient is here for 30 days and the order is still active. So if you guys have kind of that clinical knowledge that like, okay, at this point, I mean, you guys, a lot of you do, especially when it comes to things like tele or like blood work, Q6 blood work, like you'll kind of message me about his sodium's been normal for a while. Do we still need to do check BMPs every 4 hours? These things really help your workload, and it helps us too because obviously we cover a lot of patients and it's hard to go and check every order. That's just the reality of it. We should constantly check it every day, but it's not, a lot of times we don't. So it's extra work for nursing, it's extra work for techs, but it is needed for patients. That's why we put the order to begin with, but not for all patients. And sometimes we put it on admission and things are stable and the patient's just waiting for rehab. We don't need to do eyes and nose every shift or every 4 hours. Uh, so you guys, nursing and techs, you guys are bedside and you see up-to-date changes that happen with patients. So you might tell us like, hey, I think we need to do this more frequent, actually. And you'll see why, because there's things that really matter with patient care, with medication doses and everything. So the most important thing is eyes and nose kind of involve everything. It's not just, the food they eat or the IV fluids you give. There's so many things involved in it, like even the antibiotics that you give to the patient has extra fluid that come with it. And even the patient sitting there on a dry day, there's changes with their insensible fluid losses. So that all has to be taken into account. We don't expect you guys to do all the, thinking of like, how much overall the fluid was the patient has lost over the last day or two, but there's little things that you can definitely pick up and you can notice, like, maybe I should tell the attending there's some changes with this patient. Um, and it really involves, is the patient, it's like a balloon, is the patient getting filled up with fluid or is the patient dehydrated? And those really matter because it affects so many things, the cardiac function, the renal function, it can affect the liver function, especially in cirrhotic patients. Um, for all of us, usually that's all being done 24 hours a day because our kidneys are supposedly working fine, our livers are working fine, so we don't need to worry about that. Our lungs are involved in intake, like fluid status. A lot of people don't see lungs as an organ that's involved in fluid status, but they really are. And that kind of takes us to the conversation about insensible fluid losses. So again, you guys, we put eyes and nose. You might, obviously it's how much fluid did the patient drink today, how much soup they had, how much did they pee, how much did they poop. That involves, but there's also insensible fluid. That's really the water that people lose without sweating, right? Like I go to the gym and I run, you'll see me sweating, and I go get some water. You're like, okay, good job. Like you kind of replenish the fluid that you lost. But all of us will lose fluid throughout the day through our skin, through our respiratory tract, because you want to keep that air humidified inside the respiratory tract. And that happens constantly, and there's things in the hospital that affect that insensible fluid loss, such as humidity, such as if the air is very dry, like winter time, your body will tend to put more water inside your bronchioles and airways to really humidify that air. Because if that thing is dry, you're going to be coughing, there's high risk of infection. You really want to keep it humidified. So if you notice, winter times, people may lose more water. Respiratory rate. If you're breathing fast, you're getting rid of all that humidity. So if a patient is like, has pain and they're like breathing really fast, they're losing more water. So these are things that you will kind of notice. Fever. So that's the main thing. If a patient is having fever throughout the day, at bedside, you will also kind of think about that. Like, that's part of the output. They're losing a lot more fluid than they should. We don't really have a burn unit here, but we have people with really significant ulcers and openings, and your skin is a major barrier to prevent from water escaping your body. If you have a big crater in your back, that person is losing a lot more insensible fluid than the average person. So these are all considerations. The rule of thumb is you lose 1 ml per kg per hour for adults. So typically around 600 to a liter a day is just lost for us being alive. That's just what it is. It's not through peeing or pooping so that's a significant amount. That's why we have to keep up with our hydration, especially on days winter days or summer that we're sweating a lot. These are all kind of what fluid that we're losing. So you really have to watch out for these things in your patients, like the ones that are having fevers, they have sepsis, especially in the ICU. If you guys work in the ICU, patients that are on ventilators, it's constant open airway that, connected to the machine. There's a humidification factor to it, but also they're still losing a lot of insensible fluid through that mechanism. So the patients that really you have to pay attention to first and foremost are the cardiac and the renal patients. These patients, it's really important to really know about their intakes and outputs and also their weights, because it really tells us how to manage these patients. And that's the instructions we give them before they go home. We're like, okay, so limit your fluid to 1.5 liters, weigh yourself every day, and based on that, manage how much furosemide you're going to take. We're going to send them with a 40, and we'll put some 20 milligrams in their pocket and say, okay, if you notice you're 2 kgs above your weight, you're going to take an extra dose. That's really the only way you can measure somebody's CHF. It's, like blood work can help, like a BNP that's high or a troponin that's high. Those are all kind of BS, because when you run labs, you get so many mistakes and you can't make clinical decisions based on that alone. But if you guys as technicians and nurses call me and say, okay, this person appears fluid overload, they have had this much output, and that will change my decision about how much Lasix I'm going to give them today, regardless of what their troponin looks like, regardless of what their BNP or even kidney function looks like. Renal function is very important. So like a lot of times you may see a normal creatinine level, but the patient has made 0 urine all day. So that patient's output is minimal, and that really tells me that they're in renal failure. But although their lab looks okay, but that output that you record on the chart is very important, because me, Dr. Rahmani, will look at that and say, okay, this person is anuric. We don't have dialysis next week. We need to do something about it. But if we miss that and we wait for the creatinine to go up in the next 3-4 days, we kind of missed the ball on that, then it's kind of too late to even act on it. ICU patients, these people are on vasopressors, they're on diuretics, they get IV fluids. One day they get it, one day they're too edematous, we give them Lasix. So these people are very important to have accurate weights, have accurate eyes and nose. Surgical patients that just come from ortho surgeries or vascular surgeries, they've lost a ton of fluid. You really have to see, are they maintaining their fluid levels? Should we go ahead and start giving some fluids or not? Burn victims that we don't really deal with, but also our nursing home patients with large wounds, and dialysis patients, obviously. They do their calculations based on their eyes and nose that you document and the weights that you document. So Dr. Rahmani comes in the morning and looks at the numbers and says, okay, we need to remove 2 liters from this guy today. It's all based on the things you guys are reporting. So that's very important in the clinical decision making. And as you know, pediatric and elderly patients are prone to dehydration and fluid overload. So we don't have pediatrics, but everyone's pretty much elderly. So we really have to watch out for our patient population there. This kind of involves, the same stuff that we talked about, kind of keeping in mind enteral feeding, IV fluids that are going in, and then stool output versus emesis versus diarrhea. These all kind of involve, and I know you guys have that in your chart and you kind of documented, which is great. Daily weights has to be consistent, because a lot of cardiologists, that's all they look at. They're like, okay, this was the admission weight. This is what they've come down to. They label that as a dry weight because the patient is most comfortable in that situation. Like the patient we have in 1423, I think, he's a heart failure and a CKD patient, right? He's never going to be perfect because there's always an issue with his kidney and his heart, but he's not short of breath. He's not requiring oxygen. So that's what we label dry weight. So he needs to take that weight with him on a piece of paper home and just put it on his fridge. He's like, okay, this is the weight I was most comfortable with. He has to weigh himself every day. If he goes above that weight, he's going to say, okay, I'm going to fluid overload. If it's going way below that weight, he's gonna say, okay, I'm getting dehydrated. Maybe my kidneys are gonna fail. So that dry weight is very important for us to really like document and say, okay, this is what you came at, 200 pounds, you're going home at 180 pounds. So that's your dry weight. And that's the most comfortable you've been. So you got to keep it at around that weight. So it's really those trends that you're going to keep, pay attention to. And I just put like 3 cases here, that we've already kind of talked about, like a heart failure patient that has a 2 kg weight gain in 24 hours. That's like a big deal. If we see that, or you guys notify us about that, we're definitely going to start restricting that fluid. We're going to adjust the diuretics. Instead of 40 IV Lasix, we might give them 60. And that might save us from a lot of complications that might happen in the future. And a lot of patients are not going to know that. They're not going to say, hey, doc, I feel like I gained 2 kgs today. It's all from all the documentations that you guys do. A post-op patient with minimal urine output and low BP, that's like a huge red flag. So if you get somebody from ortho, you get somebody from vascular, they've had 0 output in the 6 hours that you've been on since they've come on the floor, that's something you should tell, the orthopedic doc, you should tell us, get internal medicine involved in, because waiting for labs to indicate those things can take a good 24, 48 hours, and then we're going to be behind kind of all the clinical work we're going to do. And same goes with the dialysis patients that we kind of already talked about. The final points are that, doing the accurate eyes and nose and daily weights is obviously very important. Like it's extra work for you guys, and it's not really for every patient. So if you notice that somebody's here that's not a heart failure, not a cardiac, not a renal patient, not like huge ulcers and stuff, they're just here for placement. Like we have a guy who came here as a social admit. If you see eyes and nose for that guy, there's no need for that. That's just extra work on you guys. That's oversight from the attending that you didn't discontinue that order. You should just tell them. So like, is there any really real reason you want me to do eyes and nose every shift? It's a lot of work. So it's always good to kind of recognize who needs it, who doesn't need it, to kind of do the appropriate care. And again, like you guys are really frontline. You see these things first before we do. And we would really appreciate if you guys kind of keep us in the loop with these things. So that's it.
Any questions for Dr. Mercani?
I gotta get that blood scan.
Yeah.
Any thoughts?
That's like eyes and nose. If there's 0,
That's for our.
that's more like an obstruction.
Yeah, I don't know how to take this. It tells me you can't cross over. I don't know.
All right. Is there some like pressing subject you guys really wanted to do next week or the week after? Next week probably is Christmas.
Next week.
Yeah. I have one about encephalopathy, which is good.
Just gonna say.
Yeah. Like,
Oh, yeah,
like our guy yesterday, yeah, that was great. Like our-
Anything is, everything that's.
really, that guy was like a prime case. You recognize that. You're like, this guy is different. You told me 3 times in the day, I brushed you off. Eventually, I came. Well, there's something really wrong with this guy. We did a CT of his head. There's cancer all over his brain. Those things matter. I did get complaints in the past that it was, who was it? I think some guy from Newark. He said, like, a couple of years I worked at Clifton, and there was somebody who was altered like 10 in the morning. Nobody was notified until I came at nighttime. They said, he's been altered from 10 in the morning. It turned out to be a major stroke. Yeah. So these things, like recognizing them early at bedside and just getting us involved, it does really matter with like how the patient's outcomes are going to be. Like you go and say, hi, Mr. Smith, how's your day? I'm great. And then 5 minutes later you go and it's just like, arm sugar up, things like that. That's a big difference. That could be a major stroke, could be a hemorrhage, sugar's dropped.
And if we circle this back to eyes and nose, think about the story that Josh Smith told us this morning about that patient who had a change in their output, in their Foley. A nurse was like, this doesn't make sense. They had major retention, ended up with a bladder perforation or bladder rupture. So these are the things we can pick up on and see. This is why it's so important.
Yeah.
We're getting some notes for change.
Any other questions for Dr. Mercani?
Yeah.
No. If you guys have any educational requests for anything, I can find you a subject matter expert. Just let me know.
Everything, like education, we can learn more.
Yeah.
Always.
Thank you, guys.
Some of this helps you guys, You're like, hey, this wasn't a typical patient that needs eyes and nose. You don't have to do that work.
I'm gonna tell you that.